Start over. I'm just joking.
Like, really, Brad? Come on now. I'll be honest, when I first started scrubbing, I hated orthopedics. Couldn't stand it. But kept getting thrown in there, started to really enjoy it. Now here I am, selling products, helping doctors, and helping students like you guys keep them ahead, keep the doctors happy, and have good outcomes for our patients. So, who knows? Who can tell me what orthopedics is? Anybody? You said you've got a bunch of questions. Do you know what orthopedics is?
Orthopedics.
You all
Something
failed.
to do with, joint surgery.
Okay, that's part of it. Anybody? Anybody know what we focus on in orthopedics? Okay, all right, that's fair. Hold on, I think I already lost where I'm at. I was looking at it earlier, so that's why. All right, so it's a branch of medicine here. We're focusing on the whole musculoskeletal system. So bones, right? Ligaments. You can hit the next one. You're good. You can hit the next one. We're gonna go down. Keep going. Right now, yeah. Bones, joints, ligaments, tendons. Right. So what kind of things do we treat in orthopedics? When it comes to bones, when you think of orthopedic surgery, what do you think we're fixing? Like, what are we doing? What's happened? Perfect. Broken bone. You hit next once. Oh, I missed muscles. Okay.
Muscles too?
That's part of this.
Wait a minute. We can fix muscles too?
Yeah. Sports medicine. We're going to get into that a little bit here.
Conditions treated.
Right. So we have fractures. What is a fracture? Broken bone caused by trauma, stress. It can be high energy, car accidents. We have multiple ways of fixing them, and I'm going to kind of point on it a little bit here. Then we've also got arthritis, which is inflammation of a joint, pain, stiffness, that sort of thing. We've got ligament injuries, ACL in your knee, the PCL, rotator cuff injury. Again, as we're talking here, we're going to fix that with muscles and sort of thing too. Got osteoporosis here. That's weakened bones. When you have osteoporosis, like Brad probably has it, he's getting up there in age, that you're more likely to have fractures as you get up in age because it happened. It's part of our body and chemistry. And then we've got our sports injuries, and a lot of that's related to athletic injuries, including things like sprains or strains. So when you have these injuries, right, a lot of people go see a doctor. Like I personally have had pain in my hand. I just had carpal tunnel and ulnar nerve transposition 2 weeks ago. I went and saw my orthopedic surgeon. Had to get it fixed. So when we're going to treat these things, it could be anything. We can start at conservative approaches, such as injections, medications, physical therapy, all the way up to surgical procedures like nailing bones, joint replacements, arthroscopies, many different ways to fix things, right? Hit the next one. One more. Okay. So we have physical therapy, like I just said. Keep going. Medications, bracing, open reduction, internal fixation. Can anybody here tell me what that is? I know you guys are all kind of new in the program, most of you.
Open.
Yeah, so it's called an ORIF. If you ever see it booked on the schedule, it's going to be booked as ORIF hip, ORIF wrist, ORIF ankle, tibia, like depending on where you are. Some hospitals are very direct on what you're fixing. Other doctors or other places put it on the board just as ankle instead of like tibia or fibula. So ORIF, open reduction internal fixation. That is fixing the bone with plates, screws, intramedullary nails, which I have here. Then you have joint replacement surgery. So that's replacing our joint with artificial implants with plastic, polyethylene, and metal. I have a couple of those things here. Right here's a shoulder. This is a reverse shoulder replacement. Goes in like this. Now we're articulating. So we're replacing those surfaces that are damaged. Then we also have ligament reconstruction. That's repairing torn ligaments like the ACL or the PCL, like I said, using anchors and sutures. Also grafts, allografts, autografts. We don't really use many xenografts. It's mostly allografts and autografts that we see where we are. And then we have osteotomies, which is restructuring the bones to correct alignment issues. It's like docs will take a saw, cut off a bone, kind of fix what they need to do. It's kind of cool the things that they can do in orthopedics. Okay, I'll go in there. So these are just some images I put up here for you guys, right? So here's a total knee replacement. This is a before. This is all your cartilage is worn away. You're now bone on bone. This patient is having a lot of pain. Well, we come in now. We make these special cuts with instruments we have that you guys will be putting together on the back table. And we're replacing it now with metal and polyethylene in between that acts like the cartilage in the knee. So now this patient can articulate their knee without any joint pain. This is an intermedullary nail. That's what I have right here. This we do.
This is going down the leg.
Yeah, this is actually probably a mid-length nail. This here is a long. This would go all the way down. We do this when you have fractures of either the shaft or this is shorter mid-length. This one's actually a subtroch fracture. It goes below the lesser trochanter. But we use this to repair these little fractures. It's kind of cool. It's a little nail goes down. You have this sliding hip screw that goes into the femoral head. You can either, this might be a lot, statically lock it where it doesn't move, or you can dynamically lock it where it does. So now when the patient goes to stand up, that femoral head is going to come back where it needs to go. This slides, allows for 20 millimeters of sliding, and it'll slide and stay in place. These patients, when they get these nails, they can almost always walk the next day.
Wow.
Okay.
Don't break your leg.
Actually, someone I know broke theirs wakeboarding. She's like 38 with one of these. Yeah. This is open reduction internal fixation, like I asked earlier. This is fixing a fibula with a plate and screws. So this is a picture from a case we did actually last week. We do a lot of revisions for certain things. So over time, you have implants that are going to fail. If you've had something in there for a really long time, that polyethylene over time is going to wear. It's just part of it. In this case, this was a really old implant. It was an implant that's kind of like questionable in what doctors do and if they put them in. Basically what had happened is this polyethylene that's here had worn away, and this is what it looks like. So for a while, the patient was having pain, didn't feel right. Come to find out, there was no polyethylene. So this metal head was articulating, I don't know if I can get it, on a metal surface like this. And all that black, it's kind of hard to see here, but all that's called metallosis. You don't want that. You want to have polyethylene between any two metal surfaces in a joint. So this is just a picture from a polyethylene failure case we did a couple weeks ago. And that's what the poly looked like when it came out. That's all the wear from over time, and it also disassociating from the metal implant. Not my company, different company. Just pointing that out there. Yeah.
I'm always confused, Freddie. What's the difference between a reverse over a total?
Oh, I'm glad you asked.
Is that up on your slide?
No, but do you? I can. No, you have a marker.
Because I know that is.
No, I actually get that question a lot. I have nurses in the OR who are like, "Wait, what are we doing? Anatomic reverse? What's the difference? Why? Like, why do we do what?" So you have your anatomic shoulder, right? Can anybody tell me? I'm just gonna say the two bones that are part of your shoulder. We're just gonna go two. I'm not gonna ask for all three. What's your main shoulder bone? Your main arm bone, big one. Correct, right? So you have, and bear with me, my drawings aren't great, and since I just had surgery, my hands kind of messed up. Here's our humerus. It's kind of small, sorry. When you're doing an anatomic shoulder replacement, you're cutting off this humeral head, right? But we're replacing it now with another piece of metal. And actually, I have an anatomic. Right here. So you're cutting off this humeral head, right? We're going to replace it now with metal. So you put this guy in here. That's your humerus, your new humerus. And we're putting this head on it, this humeral head. So this is like we are replacing our normal anatomically joint, normal joint. Then you have your glenoid that it articulates on. For that, we're putting in a piece of plastic, polyethylene for it to rotate on, which is this right here. So now this articulates with this head, keeping our joint anatomic, keeping everything the same. When we go to do a reverse, we're doing a reverse typically when patients' rotator cuffs are compromised. There's no rotator cuff because your shoulder joint relies a ton on your rotator cuff. That's how we're abducting, adducting, moving your arm around, lifting, pulling. It's your rotator cuff. It takes huge forces. Over time, it deteriorates. We have injuries, rotator cuff tears. At that point, you can no longer do this and anatomically restore it. Now we have to reverse the biomechanics of the shoulder. So now what we're doing is we're doing the same thing, right? We're going to make our cut. We've still got our glenoid here, like normal. But we've cut this, and we're reversing the mechanics. So now instead of putting a ball here, we're going to put a ball here. We're going to keep this surface flat. And now we're going to rotate. We've reversed the mechanics of the shoulder. So now instead of relying entirely on your rotator cuff for your movement, we're mostly relying on your deltoid muscle to do that. So that's the big difference. And so instead of the plastic being here and articulating, now we have this piece here is going to go into the glenoid, screw in. Then you have your ball, which would normally be here, on this side. With your, which I'm not sure what I did with it. We'll just take this one. With this now. So your polyethylene is on this side instead of over here. And you're just, like I said, you just reverse it. Ball's on this side instead of the other now. All right, you can go on to the next. This is just a femoral head from a total hip replacement we took out. I have the picture because it was like probably 120-pound female. No, but we pulled this head out and it was 55 millimeters. A typical woman is like 44 to 49 maybe. Men are typically like 49 to 52. We pulled that out. My doctor was like, take a picture of that. That actually was the biggest head we took out that day. They just got smaller throughout the day, and they were men that we started doing after. So I just thought it was kind of a cool picture that I had of a femoral head after we cut it out. You take, when you're doing a hip, you take this cut guide. The doctor puts it on the femoral side to get their angle. Every company has their own thing. They cut it, and then when you go to pull that head out, this is what you're pulling out. Okay? This is actually a video. I don't know how to make them play. So this is just a video of different implants that we had. Right here, you've got total knee implants, different types of things you can do. This right here is like a revision stem. That's your primary, that's a cementless, because now we have cementless implants for knees. It's going to work. Oh, I do have my flash drive. Because my other video is the one I really want them to see. It's pretty sweet.
I would keep in mind too about, obviously orthopedics is, you guys haven't gone over it, but eventually think about with your externship, what would you like to ask a rep? I think the reps are best.
I was going to say, I will tell you, your rep is your best friend in the OR. They know your doctors. They know what they like. If they're a good rep, they know the sutures. They know every single step. They know the protractors that aren't even ours. Hospitals have their own sets. It's our job to make sure that the doctor has everything they need, but it's also your guys' job to make sure that they have everything they need. So if you have a good rep, work with them. They will teach you. I actually have a scrub tech that I work with quite a bit now, and I like to think that I've had a lot to do with her and now becoming this doctor's primary scrub tech on Friday. She comes in on her days off. But she took the time. She would call me after hours, ask me questions about the surgery, ask me, what can I do to get better? And we just built a relationship based on that. Man, it worked on my computer. Well,
We're going to have to pivot.
yeah, we'll do that. So anyways, the next one won't work then either. Hit spacebar, enter. There we go. Okay, go back. So this is what I'm going to show you next. This is new, intuitive stuff that they're coming out with. So, yeah. Okay. So this, what my doctor here is holding, is called a concise. Oh, are you going to try it?
It's just the other one.
It's weird. This is called a concise gun. That is what I have right here. This one actually, it didn't work, which is why I have it. But when I put this battery in it, which is supposed to be dead, it actually did something, which is kind of strange. This is the doctor you were with the other day, yeah.
So this is what I missed.
This is what you missed when you left. It's called a concise gun. Doctor uses it to broach the femur. That's what she's doing right now. She's prepping the femur for this implant right here. She loves this thing. She's like, yeah, she loves it. It's a great tool. One other company has it now, but we were the first company to come on the market with it. This is an older version. Like I said, it's dying, which is why I have it. And I brought it to show you guys. You can play with it after. I'll show you how to put some of the attachments on that we have. With this, you can broach the femur, as well as we use it to put in our final cup implant, which is right here. So here's your cup, right? So you ream the whole acetabulum, we go to put it in. You have this little attachment that goes onto it. Doctor can then put it on their gun here. Or actually, you guys are the ones doing it. Goes on, hits the button. They can use this now to put in the acetabulum, which is this part. and what your femur that she's prepping there is going to articulate with. Okay. Like I said, I brought some of this stuff just so you guys can get your hands on it, play with it, whatever. This I thought was really funny. A couple weeks ago, scrub tech wasn't in the room. Doctor scrubbed in. He's standing there. This is a hospital too where they 100% on rules, 3-minute dry time wait. So the only thing they can do is their down sheet. He gets very impatient. This is what happens when your doctor decides to drape without you. That 3/4 sheet is not on correctly at all. And he's standing there looking at it, and he's over here trying to move it around. I don't think he realized at all that he put it on completely the wrong way until the scrub tech came in. So I just thought this was a good little slide to throw in there and show you this is what happens when you're not in the room and your doctor tries to do something without you sometimes.
That's the patient's head right there.
Yeah, this is for a shoulder. This is a shoulder replacement. That's what the doctor puts on before we prep and everything. But that 3/4 sheet is not on. I don't know if you guys have gone over draping yet, but that is completely incorrect. So, what is your guys' job, right? We'll hit it once. All right, so first we have, pre-operatively, what do you think you're supposed to do, right? Your job is to ensure everything is ready to go for the surgical procedure. You're to make sure the entire environment is sterile and it stays sterile. Set up your instruments, equipment needed, such as scalpels, retractors, in my case, drills, saws, anything you're going to need like that. And then just ensure everything's available and in proper working order before the doctor gets in the room. So then we're going to go, also inventory management. I forgot about this part. Big part important in this job, counts. Counting before the surgery, after the surgery, making sure everything is there. And also making sure nothing's expired. Does anybody have a guess what what I personally think is the #1 most expired thing in the OR? I want to know if you do know.
Sutures.
No.
Oh.
And it's actually happened while we're in revisions and nurse goes to open it. Cultures. Culture swabs that come from the lab because the lab just comes down, throws them in the bin. If people aren't checking them, that is your guys' job to check that stuff and make sure. That's the #1 thing I see expired in the OR. So intraoperatively, it's your job. Maintain sterility. Keep the sterile field the whole time. Make sure, monitor everybody in the room. Make sure nobody's getting too close to your field. Make sure, nobody's touching their own thing. I had a nurse once, had everything set up. It was a heart nurse, came down to help us, opened up my cement. Well, she didn't realize there's 2 other packages and opened up an unsterile thing of cement on my table. Whole thing done. Restart the whole case. It was Pat.
How short one did you see?
No, it got a little better. Suctioning and hemostasis, making sure that the surgeon has a clear view. They can see everything they're doing, see what they're looking at. Assisting the surgeon, that's part of that. Making sure that they have what they need, handing them their things, anticipating their needs. That's a big thing. A surgeon wants to come in, do their job, take care of their patient, have the same result, especially in orthopedics. It's like, for the most part, it's the same. You have things that deviate, but they want to have reproducible results every single time. So assisting your surgeon, making sure they have what they need, huge thing in the OR. And then making sure, your equipment is operational. Everything you have is working. The jigs, when you're working with me and we're putting together cutting jigs and stuff, I'm going to have you check it, make sure it's moving right, make sure all the moving parts go together. So when we get in the case and the doctor hand it to him, we don't hit any surprises and slow things down. Post-operatively, transporting the patient, cleaning the room, and essentially getting ready to do it all again with the next doctor and the next patient. Keeping things moving. You can go ahead and next one. So my tips for you guys: communicate effectively with your OR staff, your doctors, your preceptors, whoever you're working with. Maintain that clear and effective communication, just to ensure a smooth workflow. Ask questions. Seek feedback. Don't be afraid to ask questions. Your preceptors are there to help you. I will be honest, you will have some preceptors that probably aren't the happiest to have you there. Doesn't matter. Take what you can from them, because if there's one thing I learned multiple things from all my preceptors, and I probably took something from each one and made it my own. So ask questions and don't be afraid. Learn from your experiences. Develop your skills. Stay up to date on new technologies if you can. This field evolves every single day, just like this gun right here. New to the world, everyone loves it. Cross-train, if you get opportunities in the OR, it's really good to broaden everything you can do. It makes you more hireable, makes you more needed, it's great to have that knowledge. And then just learn from every experience you have in the OR. Reflect on like what went well, what didn't, what can I change. Demonstrate professionalism, acknowledge expertise, recognize and respect the surgeons, nurses, and staff, and just show appreciation for the skills and the things that they're teaching you. Be proactive, try to anticipate the needs of the surgeons. Being proactive in the instruments and supplies and having what you have, it's going to streamline the surgical process. It's just going to make things so much smoother and easier for everybody. Take the initiative to, like, if you see an area you think you need improvement, or if you see somebody that you think you can help, maybe a little bit more, like in the future, don't be afraid to like talk to them and ask questions and try to help. Be adaptable, probably my number one thing. You hit next. In the OR is ever changing. I say orthopedics is a lot of the same, but not every surgery is the same. Same thing like gallbladders. Take out a gallbladder. It could be the steps in the book. You go to do your next one, and now they've hit an artery. Or just be prepared, be adaptive, being open to changes and everything. Because honestly, that's key to a dynamic OR environment. Showing respect, obviously. Maintain a positive attitude. It can get tough. There are days where you're going to be like, oh, I want to give up. I'm done. I can't do this. My preceptor's so mean. They're not helping me. Just try to be positive, because it does get better. You will have those bad days, I promise you, but you'll get through it. Learn your skills, and you'll be a great scrub tech. And build trust. My big thing here. When the surgeon knows that you come prepared to that room, who do you think they want in their room, right? The tech who's going to make it easier for them to do their job is the tech that they're going to want in their room. Again, doctors, they want reproducible results every single time for their patient. They want good outcomes. They want the tech who's going to help them do that. So, by fulfilling all this, I feel like this is what helps ensure, orthopedic surgeons have what they need and things are conducted the way they should. And there's just some pictures from us in the OR. She worked at St. Andrews. No, her name's Lori. She worked at St. Andrews, but now she's at Murdoch Surgery Center.
Awesome.
And then you got Dr. Ing, Kira, the PA. And actually, here's Carrie. She was a scrub tech here. She's the one I was talking about that I talk with all the time and has called me after hours. And then that's me with we have hip navigation to where the doctor, I have points I put in a computer. We take x-rays and we can determine leg length, offset, try to get whatever the doctor's trying to get to.
Awesome.
Nice.
And so that is orthopedic surgery in a nutshell. So I do have, like I said, I brought the gun for you guys to mess around with. Let's see.
Before you do that, do you mind if I just have them do like a Q&A real quick?
Yeah, absolutely.
I know they really want to know a little bit about your story. I just talked about one individual in particular, but how you became, was there networking? Obviously, you made a transition and become a rep. A little bit about that. But you guys, it's open. This is your time to ask questions. Externships. What are some advices, the do's and don'ts for students going out there, right? So I know Nico probably want to start off a little bit about some questions.
What was your main reason for swapping over?
I have a very unique story. I did not go looking to get into this. I used to joke with my rep that I would take his job one day because I always would go get his trays and I don't even know what you do. I do your job for you. Now that I do this job, it's so much more than I thought. But I actually had the team lead come to me when they lost somebody and ask me if it was something I'd be interested in. And I went back and forth for a while. We had meetings with my husband because this is a lifestyle like this right here. It's a full-time gig. I do stuff at home. Like, it takes a lot of time. But I thought about it and I said, I'm still certified. I keep up my certification because you never know what's going to happen. But I thought to myself, I'd be really upset if I'm not doing these knees and hips that I know how to do, and I've got some random person that I don't know telling me what to do on the other side of the table. I was like, I got to give it a shot. If I don't give it a shot, I'm never going to know. So that was what I told myself, and I went in with the mindset I can always go back, and here I am 5.5 years later, still doing it.
Okay. Are you happier this way?
It's got its good and bad days. What I like is I'm not stuck in the same hospital all the time. But I miss scrubbing. I miss vascular surgery a lot. I really love doing that. I did a lot of vascular. And I did quite a bit of neuro in the beginning too. So I do miss not being able to do all of that. But having my skills and being involved in all the things I was as a scrub tech, because I wouldn't specialize, I did everything. It's actually made me a lot better in this role because I know other instruments, other products. other things that can help the surgeon in the OR and come up with weird things we can put together that are probably totally off label, but we make it work.
Okay.
Hey, you got a question? I saw you raise your hand.
Don't be afraid. If anyone has questions, like this is the time.
What were some of the downsides when you were
Terrible preceptors. You can have some preceptors that just don't care. Trying to prove yourself, like it was a lot in the beginning, I feel like. Once you get out there though and you get confident in your skills, you're going to see a change. I'll be honest, as a scrub tech, I truly feel like it takes 2 years to be fully comfortable in everything that you're doing. I think it probably took me 2 years to where if I got called in, that's when I'd be like, okay, I can do anything. There were times I get called in for things I'm like, I've never done this before. But at that 2-year mark, you really like, you've seen a lot, you know more of the instruments, you've seen different specialties, and I think like at that point, the confidence comes. That's probably the biggest thing. It's just the confidence in the beginning. It's difficult because it's a lot. It's a very technical job. And patients are relying on you guys. Like, you don't want to get an infection. That's terrible. Absolutely terrible, especially joints. Big deal. Months and months and months of antibiotics and just a terrible situation. I always just looked at it as, how would I want my family member treated if they were this person on the field? If they were this person we operated on. And that's how I did my practice.
So what do you do in the moment of you did get called in and you've never worked on this case before?
You hope you have somebody on call with you who does know, and fake it till you make it.
All right.
Read as much as you can. If you're called in, you're not going to have time to study. But if you're going in the next day and you know you're doing a case that you've never done before, get online, get on ViewMedi, get on Google. You can find videos on YouTube and just study things up, study the instruments, and just try to get yourself familiar with the steps and the anatomy. Once you know that, it's a lot easier to kind of fake it till you make it.
So Brittany can attest, but it took me about a year to get my. So when I was on call, it's a craniotomy, shrug away and stuff that could happen. So yeah, you go in there, it's a hot mess, right? You get through it. So that's on during the day. Find those cases, get better at it. So find the cases that you're not very good at because you're stuck in your niche, orthopedics or something like that. You see a case like craniotomy, don't run from it. Say go in there just for the fact that you can get experience at it.
And when you guys are in school, it's a perfect opportunity for that because you're going to be with somebody. You're going to have a preceptor. So those are the moments to get in those cases that you're unfamiliar with or you're uncomfortable with because that's how you're going to learn. And then when you do get a job, you'll have already seen it. Go ahead.
Is there a reason why you never completely specialized when you were scrub teching?
Because I think it makes you a lot better of a scrub tech. When I was there, we needed ortho people because they were going up to the heart team, and they kind of wanted me to just do that, and I refused to do it. I was like, I want to learn everything, didn't specialize, and I mean, it got to a point where I had different doctors in different specialties asking for me in their room, and I just think it makes you a better, well-rounded scrub tech and able to fix different problems that can arise.
You get stuck in a niche, but it doesn't mean that you can't branch out, right?
Yeah.
If you're interested, you're absolutely right. On call, it's probably in your interest to learn everything. If you do an ENT case, it's probably your interest to have an understanding about it.
Yeah, you're going to get called in for nosebleeds in the middle of the night, unfortunately.
You start mumbling off ENT stuff, and you're like,
You're like, Takahashi, what? I don't know that instrument. Like, what?
More or less, the doctor will guide you along, but yeah, it's embarrassing, but eventually you learn it. Hey, I better learn that because of on call.
Yeah, on call, you're getting called in for anything.
Yeah.
You don't have a choice. Go ahead.
So for someone that wants to get into the rep world, what would you say the steps would be to get there?
So the people I've seen getting into it now, it's big networking. A lot of companies are doing events and hiring events and that sort of thing now. But what I've seen is the better reps that have come out are the ones that have the experience, have OR experience, have some sort of medical background. Coming straight off the street, like we've gone through 3 different guys on our team just trying to find someone to stick because they just don't get it. So knowing the sterile field, knowing the OR, I think is a really big part of that too. Makes it a lot easier for the transition.
It makes sense because if the rep doesn't know what you're doing on your back table, like every variable, the doctor would turn eventually to the rep saying, what's going on here, right?
Yeah, no, there's times I've had a doctor look at me like, what the heck is going on? I'm like, I'm sorry, I don't have my laser. Like, it's a scrub tech. I'm not sorry.
Like, could you imagine someone coming off the street with more of a business degree?
And that happens, and you should see them in the OR. They're like a blind sheep trying to figure it out. So,
You start drowning, they save me.
Yeah.
If that's what they have
Yeah, your rep will be your best friend, especially in orthopedics, because when you do start like getting behind, it's my job to keep you ahead and keep the doctor happy with you. So we're here to help. Go ahead.
Do you have a question?
Is there ever been a time where you were too like worried of asking for help, and then due to not asking for help, it turned out worse?
I'm sure there's been multiple times where I probably should have asked for help, and where I've run into situations in the OR as a scrub tech. But I also learned when in school, I really learned to listen to my preceptors and like ask questions. And if you're I will say, a lot of the preceptors that do like teaching, if you're somebody who's going to go to them and ask questions, they're more apt to help you. So I just kind of learned early on, try not to just figure it out on your own if you don't know. Once I knew a little bit, I could kind of piece things together and figure it out. But I think it's definitely better to always ask for the help or
As a
information.
rep, that's probably because you don't want that tray, the only tray that you have to be contaminated.
No, from my scrub tech background, I always try to have a backup because you just never know.
But that being said, if you're not making a mistake, you're not learning.
Correct.
There's a fine line there, but the point is, if you're staying in the safe zone, make a mistake, right? Not a big mistake, but if you're going through the motions, right, you're trying, that's a learning experience. To me, that gets ingrained in my mind. Don't do that again.
Yeah, I mean, I could tell you just an example from when I was in scrub tech school. I'm opening for a hand case, like no big levy, no big deal, easy case to set up for. I'm not paying attention. I was talking to somebody. All of a sudden, I looked over. I had opened all of my stuff in my basin and thrown my garbage in there too.
Oh.
And I looked at him like, well, but the upside from one of my preceptors I learned, don't open on your back table. So everything was in my basin. So my back table's still fine. It was just a whole contaminated basin. It was all soft goods, so it was fine. Don't worry, I didn't slow him down. Anybody?
You're awfully quiet today.
Go ahead.
This is like
Of
opposite
all the
of one.
specialties you've done, what do you consider the hardest?
Vascular. I think there's just so many wires, catheters, so many different things that go into it. It can be extremely overwhelming, especially you get put in like a endovascular AAA and you've got a basin with 15 different wires and you don't know what's what. That was probably the most intimidating specialty to get into.
Like, since you know all these specialties and stuff, have you ever considered doing traveling, like a travel search there?
So I did at one point. I thought about it, but I got married. Had I not gotten married, I definitely would have traveled. But I was 27, 26 when I got married, and it just at that point wasn't feasible. But I also feel like in order to be a good travel scrub tech, because you don't get orientation, you're just thrown into these things. I personally think that anybody who goes into traveling should have 2 to 3 years as a normal scrub tech before you even try to get into that field. Yes, it does pay better. Yes, you get to see a lot, but you can't fake those situations. I hate to say it. Like I say, fake it till you make it. It is very hard to fake it in a travel situation because you don't get an orientation. You were just thrown in.
The worst thing to say if you're a traveler is, I don't know this.
Yeah.
You're getting $42 an hour, you better know.
You better know it. You better be able to do every single specialty. And the staff that's there full time that's not getting paid like you, they're not going to make it easy on you if you can't do everything they can do plus some. So that's my advice there when it comes to traveling. Definitely get 2 to 3 years experience before trying to get into that. Yep.
Knowing everything that you're doing now, going back to your externship, what would you do to make sure you have a solid foundation for confidence, success, and just make sure, like,
Again, asking questions, not being afraid of that, because I was very much of an introvert. I like to go around and keep my head down, like just go in, do my job, and get out. Now that I know what I know, I think it's a lot better to go in and ask those questions and don't be afraid and just try to get your hands dirty. Try and help. Try to help your preceptor. Pick cases for them. Pull things out. Get there before them if you can, and just have things thrown around the room. I think that's a big part of your growing process and learning process is just learning every single thing about this job. Like, it's not just passing the surgeon instruments. I mean, you guys are there setting up the rooms ahead of time. You're pulling instruments. You're making sure you have everything that you could possibly need because you don't want your nurse running in and out of the room during the case. They have other things to do. A good scrub tech is one that's going to have everything prepared and even be thinking of the backup things they could possibly need. Now, granted, you don't want to pull too much backup stuff because you're the one putting it away, but you always want to have everything that you can possibly think of, in those situations. So I think just asking questions, being well-rounded, getting there before your preceptor, just trying to make things easier for everybody. Those are the things that are going to help you be a better scrub tech. And the preceptors will want you in their room at that point. Like, I think with us, like, we didn't really have too many bad preceptors.
Yeah.
Where like they'd be fine with us, like they wanted us in their room because we did their job for them at one
I
point.
tell you guys when you get the externships, it's about you have to being a student's hard, right? Because you have to be seen and heard, ask questions at appropriate times, and then go in a room where you feel like you're not wanted. All this is a learning experience. It's not going to be perfect.
No.
Life's not perfect. I wish it was, but for us, I know when I was at Sharp Point, we had Ken, which was
He was great.
There's usually someone you can gravitate towards. And obviously, Brittany was a student. You were hired before I was.
Yeah, I think I was one term ahead of you in school.
So it's like you have people that you can gravitate towards. Those are the people you try to learn to. Doesn't mean that you can't get away from being stuck in a room with a person like, I don't like this guy or this person. You still got to go in there, be professional, and learn the best you can.
You got to get through it and learn what you can from them.
I was going to ask you, I know, in the sense of do's and don'ts for students, because I always have a hard time letting students know what they can do. Give me an example of a good student coming in there and a student that's probably not so good.
All right,
Like
so
your experience.
my experienced student that I think that do better, they're the ones that get there early. They have their morning scrub done before they've even gone in the room to do anything. Because again, that's 3 to 5 minutes that you're wasting time. So get there early, get that done, get that out of the way, be dressed out, ready to go. Having your cases pulled, like I know it's hard, especially when you're new in externship. It's really hard to go in and like know what to do, where to go. But I'd say by your second externships, it's still 2 terms, right, of externships. You should be able to walk into the OR, right? Know where to go, find your case card, pull your instruments. You can't open anything without anybody there, but have those instruments pulled. Have your case cards ready to go. That way when your preceptor walks in, they can just check it, and okay, good, you're good to go. And then you can start opening. Those are the ones, and just be prepared. If it's something you've never done, get there an hour early. If it's a big joint case, get there an hour early and look at that stuff. If it's something small, cysto, 30 minutes early. But if you don't know it, you're not familiar, get there and look at the things that are in those bins ahead of time and see what's pulled, see what's on the preference cards. I'll be honest with you, put it lightly, preference cards suck. It doesn't matter where you go, they suck. Doctors complain about it, techs complain about it. I don't know why, but every hospital has this issue with their preference cards. Something in the system glitch. I don't know if they use the same thing or what. They're terrible. My advice to you guys, get a book. Keep notes. I had a pocket book that I kept in my chest pocket all the time. And I had surgeons' gloves, draping, steps of the surgeries. And I actually still have, when people do ACLs at the hospital, because they never do them there, I have techs text me, hey, you still got your notes for this doctor's ACL? And I just send them a picture of my book. I think that's the biggest thing, is taking your own notes and making sure that you have what you need once you're there and familiarized with your facility and your doctors. That's a big thing. But just being prepared.
An example of a bad tech rolling into a room and the case is already halfway done.
Yeah.
You don't mind me counting this case, do you? So I mean, at least some preceptors, if you're going to be a part of a case,
Be there early.
be there early. Don't roll into the room and just try to scrub into a case.
Yeah.
They know because
That-
they're the same scenario.
When I was a preceptor, I'll be honest, that was my biggest pet peeve, was having students, like, I'm there 45 minutes early, I've already started opening, and you haven't even done your morning scrub. That was probably my biggest pet peeve, and I got to a point where I'm like, if you're not here to set up, you're not scrubbing this case. And I'm the same way now with new reps that we have. If you're not there before me, making sure that things are ready to go, you're not running the table. I just think that's a really important part, because a lot of, I hate to say it, we had a lot of really bad scrub tech students come through where they just would walk in and just think, okay, I'm here, I'm getting my hours, they're going to let me do it. No, because this job is so much more than just running the table. It's so much more than handing a surgeon instruments. These people's lives are on you guys. You might not think it's a huge deal, but it is. Like, it is a really big deal. Infections are a huge deal in the OR. And just being ready to go and proactive and paying attention to things and giving yourself enough time is a big part of it.
Another question I forgot.
Sorry.
You had a question back there. What was that answer?
Don't be afraid. This is the time. Like, if you guys have questions, if I can answer, and I will do my best.
Is there ever like a time, like, pretty sure there is something like to help besides or in the surgery, tell the doctor something that you just did a new way, like the other day.
Okay, I can give you an example. We're doing a hind foot nail. We're removing one. So now you've got a huge void in the bottom of the foot. The doctor wanted to pack some bone graft, some osteogenic bone graft in there. And he's like, well, how am I supposed to put this in there? I have nothing to put it in with, like a syringe or anything to get up, because now you're talking about a bone void. Sorry, I just had surgery. I have a Band-Aid on my hand. I'm talking a bone void that's probably like this long. Well, because we were removing the nail, when you're putting something like this in, you have different jigs. It's a lot of percutaneous cannulas and stuff. So the doctor said, you know what? Put your bone graft in that cannula and then take the inner trocar and use that to push the bone graft up. Worked like a charm. He looked at me, he's like, good repping. But it was just something I even knew from like vascular and cannulas and putting those things, even laparoscopic and the trocars. Like, you're putting that in, it's closed, obviously it can push something through, so it dawned on me I can use this trocar, fill up the cannula, use the trocar to push the bone graft through. And it worked great.
The Bretney technique.
No, I did not. I'm sure there's an instrument or something out there for it already, but
Good question.
Yeah.
So because you were diverse in all kinds of fields,
Mhm.
skills, and what you've seen, it was able to help you assist the doctor in that sense.
yeah, absolutely. And that's what I said when I said earlier, like, but piecing things together sometimes, like just knowing your different instruments and things that you've done with them, you'll start thinking about creative ways to fix problems in the OR. Or something, you say, oh, wait, doc, I know, hold on, there's a cannula I know we can use. Or, hey, doc, there's, this tubing that I think will work great for this. We've had to piece together tubing for, like, pleurovacs for the chest that, we just didn't have all the pieces for. And think about things you have in laparoscopy that you can put together to make it work for that surgeon in that moment.
I think doctors want you to think outside the box. What's the worst case they can say? No, that's stupid.
Yeah, I get that a lot. I get that. I still get that.
Yeah, man, don't be scared to get that response, because most people are like, should I say that one? Maybe it is a good response. They want you to think out there. There's a bleeder down there. They want you to say something. There's a bleeder
Yeah, if you
down
see
there.
somebody like, hey, doc, you got a bleeder, they may be like, yeah, I know, but you've done what you have to do to speak up.
That was the biggest thing for me is, when should I ask questions?
Yeah,
Most doctors we were part of, we didn't probably want to say too much because they're aggressive.
yeah, some of them were.
But the point, I guess, most doctors are, they want you to speak up. They want you to be a part of the case.
And then you'll also be able to tell, too, there's going to be doctors who really like teaching, that like having you guys in the room. Those are great doctors. Like, you'll figure it out. Again, read your room. Read the people in the room. Get to know the people you're with. How long are we on externship? 3 months at each one? Yeah. I mean, you got 3 months with these people. By that third month, you should be able to read that room and know what doctors you can ask questions to, what doctors, want you to speak up, which preceptors you can ask questions to and that sort of thing. But I would say most of the doctors are pretty good with students if you have a question. As long as you're not asking questions the whole time, because they're there to do a job too. Find the right moments. If you saw something during the case that you had a question about while they're suturing, hey, doc, do you mind if I ask you this question? Because at this point, they're not thinking about what they were doing before. Surgery's done, now they're just closing. Those are the times to ask those questions too, I think. Finding the right moment during the case.
Yeah. Did you have a question?
So when you say aggressive, can you give an example, your worst doctor aggressive?
You already know where I'm going to go with it.
What?
Probably the same story that
Well, he's a doctor that he would go and, let's say we're doing a uni knee, and they're very difficult to get the poly in. If you know where I'm going. He'd drop the implant. And he would look at us and be like, what did you do? Why did you drop this? Do you have another backup? To the rep, freaking out. And I'm like, dude, you dropped it. Sorry, sir. I apologize. Even though it's not you, I apologize. Sorry, it won't happen again. And he was crazy. He actually accidentally hit a scrub tech with a door one day because he was really upset that they were wasting time and weren't in the room. And what's going on? He didn't see the scrub tech and hit him in the head with the door.
And who was the tech that they put the person in with? Brad. Brad, come on in. We got a doctor for you.
Yeah.
So he would tear me apart the whole case.
And then afterwards, hey, Brad, great job. You did a great job, Brad. This was this guy. He has since retired, so you guys won't have to deal with him, but yeah.
Well, it's getting to about past 9:45.
Okay.
One more question, otherwise I'll let Brittany go. She has to go save lives, right?
Just do a few shoulder replacements, fix some bones, give people their lives back.
Other we have a test in this class, so
Okay.
there's no more questions. You guys can come up, put your hands on some things, and last
Yeah.
weekends, last call for alcohol, all the above. Come on up here and just ask questions.
Yeah, feel free.
Otherwise, thank you.
Yeah, I'll give it like 15 minutes with this stuff if that's cool. Thanks, dude. Thanks for helping me with it all. What's that? Yeah, no, go for it. Pick it up. This one's like technically, it's technically broke, so.
It's so amazing to see where they've come from.
Look at
Now remember, I've been in the Army for 60 how much years. RNs don't know how to scrap in today's world.
There's
Hey guys,
maybe
my
a handful of RNs
You
that I
could
know
come
that
from
can
one
no,
end
100%.
and have fingers.
That's it always
So I
blows
always
my
tell my
mind.
techs, your nurse,
Thank you. Nice to meet you too.
Have a
your
donut.
nurse does not read.
No,
So
they don't.
befriend them
Yep.
and let them know. Yes, don't drive until you get the eyes and say, "Are we ready?"
Yeah. Yep.
That's what I tell them there.
Yep. It's a
It
big
is
deal. This for hip. This, yeah, this is for this right here. What he has in his hand. So these are called brooches. And this is what you use to broach the femur to get the correct size for the implant.
And this is the actual implant?
That is an actual implant.
Okay.
I made the mistake and opened the wrong one, so now I have a DNI. Now I have a DNI. And then I work with the design surgeon for this, so we've had a lot of mistakes in the beginning learning. So I actually have a whole DNI kit of anatomic reverse shoulder.
that is when I came out, they weren't doing shoulders yet.
Here, try and put that thing on. Yeah, no,
They
it
weren't doing shoulders yet. Another thing I read
blue
about-
handle all the way up.
Which is the,
They another thing they did.
Right.
Was that
Other way.
ankle? I think they weren't
Yeah.
doing it yet.
So, like total ankles,
Yeah,
there's actually only
the trial.
And then put the
two
blue handle down.
companies that have a total ankle. They don't do well historically.
I
See, it's actually working right now. I'm shocked. So, this.
I feel like I swear it's broken.
So here, now you're going, right? Doctor's putting their cup in. Now you're gonna put this on there. So you have right here, it's a locking button, right? So that little circle shows you're unlocked, and to turn it, you're locked. So you're gonna push that in, you're on unlock.
Sizes of femur head.
Push it all the way in now. There you go, and then turn it to lock. And then you can go ahead and hit the button. And so that's how they're putting that in.
Let me see that.
No, actually, so they have, I don't know, you might see it, you might not.
That's
There's a thing
crazy.
called a woodpecker. And it was like this. They hooked it up to pneumatic pressure. It caused a ton of femoral fractures. This has only 6 joules per impact. And it's designed to actually stop when it hits a certain like pressure tension. But this thing works sometimes great with the cup. A lot of times we take it off and hit it in with an impactor.
Want to put it? Go ahead.
I'm super excited that thing's working. That might give me another gun now. Woo! Yeah, I don't know why. It's just
So
working.
cool.
It's so great to see you. Oh, I was like, I'm not gonna know anybody there anymore.
You do that to yourself. Yeah, exactly. No way.
It's great to see you.
And I do teach.
Right. Not here. Yeah, right.
Okay.
Yes.
Oh.
I teach over there.
Okay.
And all my LPs are about the good.
actually hurts my ears.
Good. Gave me
I'm
a
not
hot
surprised
strap.
by that at all. Like I learned so much
Yeah,
from you. You were a great teacher.
I enjoy it. And if
You were
you
good at it.
enjoy it, you make
You're doing better that way.
Pretty sure that's what this is for
I
it.
keep us up here and tell them if you could volunteer in a serum processing.
What's the
go
difference?
do
Yeah,
it.
learn the instruments. Those are
Oh my
femoral
gosh,
heads.
yeah.
This one's
Same
femoral
thing?
head. This is a shoulder for reverse.
Okay.
That's a femoral head. That
Take care.
goes.
Got it.
Hey, thank you so much. Where's that stem? Oh, that guy. 20 years. 15, 20 years. So rule of thumb with these. So this is what this is. This and then this guy. This would have a piece of polyethylene that snaps into it. And then this articulates and that's your new hip.
Okay.
And ceramic lasts longer than metal. So you have
Got it.
ceramic and metal heads, but just about everybody goes to ceramic.
Cool.
And these are the trials. that determine
Yep,
the
these are
size.
your trial heads. You have 32s and 36s in this set. These are 36s that I have right here. Now, different companies have different stems. Ours, because obviously if you cut someone's bone, right, you don't want to make them short. You don't want to make them long. They're going to feel that.
Yeah.
So you have different heads, and they're kind of hard to see. This is a 1.5, and this is a 12. But the way they work with our stem is they're slightly different in their sizes and the way that they sit on here, and it'll add your leg length back with those.
Okay.
So that's why you have trials. And again, you can trial off these brooches, right? This is a 7. You throw a neck on it. and you can trial right off here because that looks just like this. Or you can trial right off of your final implant if you're worried about where it's sitting. Doctors will sometimes trial a different head just to make sure that it's in the same spot.
Cool.
Now, orthopedics is fun. Like I said, I didn't like it as a student. As I kept doing it and got really good at it, I started to really enjoy it. And I've learned a ton since being in this role. Things like when I was a scrub, first telling me, hey, grab that 2.5 drill. You're going to need this star drive screwdriver. I didn't know why, but doing this, I've learned now why.
Okay.
Why I use that drill for that screw, that sort of thing.
Interesting.
And I teach that to my techs too when they ask. So.
What do you think the second hardest thing?
All right, well, let me know if there's anybody's getting out a while.
Second hardest after vascular. Neuro's a lot because there's certain things you can touch, certain things you can't, certain things compatible, and then I think orthopedics should be good. But it really depends on like where your strengths are. For me, I'm not mechanically inclined, so I'm like ortho's terrible.
All right.
But it's a matter of where your strengths and everything are, I feel like, too. But for me, it was a vascular, neuro, and then ortho. General was easy.
Right?
Urology was easy. ENT, the instruments are just really weird names. So that was difficult. Down here, we do a lot of laminectomies, a lot of spinal fusions, cervical and lumbar. When we were in school, we were lucky that there was a neuro guy who actually did a bunch of cranies and stuff. In this town, they're not doing a whole lot of neuro anymore. They're shipping a lot of it out. So we saw quite a few craniotomies and like BP shunts and that sort of thing. So that was pretty neat. You put in a catheter up here, tunnel it all the way down to their stomach, to the peritoneum, and it drains out the excess fluid in the brain so that the patient doesn't end up with swelling and like headaches and that sort of thing.
How would you describe your time doing neuro cases?
Neuro cases? Oh, I loved it. Like when I was a student, I got thrown in there a ton. Like every Monday and Friday, I was in neuro. Worked with a crazy guy. He was nuts. He hated women. But at the end of it, he loved me. Like once I was working there and stuff, like there's one day during Ramadan, he doesn't eat and got really like angry. And I looked at him and was like, do you want a Snickers, sir? And afterwards he like found me. I was like, I'm sorry for acting like that in the OR, like apologized for it. Cause he knew I was like, dude, I'm done. I'm not going to be in your room anymore.
What's like the hardest thing would you say about ortho? Or like why didn't you like it?
The tools. It was just so much stuff. Like without my rep, I was clueless. I'm like, I don't know what's going on. But after doing it continuously and like seeing what I had every single time, once you realize that it's the same thing every single time, suddenly it just clicked. And I'm like, this isn't as hard as I thought it was. Everyone says like a knee is harder than a hip. I spent 2 years going, I hate hips, I hate hips, I hate hips. And then one day in the middle of a case, I was like, this is so much easier. Why have I liked knees this whole time? No, it was Connors and Greenberg.
Oh, Greenberg.
Well, bipolars, but I never liked doing hips. And then one day, just in the middle of the case, I was like, wow, this is way less stuff. Why have I liked knees?
You was the day that Brittany gave me her pictures of all of her back there.
Oh, yeah, because that's another thing. I used to take pictures.
I was like, oh, we can use pictures too.
I'll never forget the day you threw a saw away.
I know.
It was not me.
Yeah, I guess his examples. He is the example.
Yeah.
Brad and I actually, Brad,
Yeah.
he is. But once we worked together just about 3 times a week. We were in the same room with the same doctors, and it got to a point where we didn't even have to talk to each other while we're setting up. And like, if I forgot something, he remembered it, and if he remembered, I forgot it. Or like, it was just one of those things. Like together, we made a great team. Doctors never were missing anything. He had his moments, of course, like he's using his examples are true. But, yeah, I mean, we all make mistakes.
That's true.
The day that, was it Meredith and Brittany kind of pissed Brad off that day?
Oh, dude, you were so mad.
And Meredith ate you a cookie.
She's the PA that works with one of our doctors.
She used to slap my hand.
Yeah, she was a lot, but.
So, what would be advice to try and get into this? Should I stay as a surge tech for like 2 years and learn everything
I
before
think
you move
I do,
over?
because honestly, we look, like when we're looking for people, we look for good scrub techs.
Okay.
Because, like, you just make a better rep. There are some that you can hire right out of school that do okay, and they do fine, but I mean, from my own experience, and I have scrub techs who tell me, they're like, dude, you're my favorite rep, like, I love having you in the room. Yeah. They get upset when they see my partners come in. Like, and then I'll come in later and like, oh, thank God you're here. Because I think my experience has really helped, and I can help the scrub tech, you know, just be ahead and look good for the doctor. Like, that's my job, make you guys look good, you know, and make sure the doctor has what they need.
Okay.
So my advice getting into this, get the experience, start networking.